Hi, I'm Dr. Doug Hoffman, and welcome to the Case of the Month. This case features an individual with carpal tunnel syndrome who is also found to have coexisting pathology. My sonographic evaluation of the carpal tunnel follows a protocol designed to identify coexisting pathology that may influence clinical decision making. You can find a detailed review of this protocol in my wrist module on Ultimate MSK. Now let's dive into the case. The patient's history includes the onset of bilateral carpal tunnel syndrome symptoms approximately 8 months prior, initially presenting as intermittent numbness and tingling in the median nerve distribution, along with occasional volar wrist pain. She also reported long-standing basilar thumb pain. The numbness became constant about 2 months prior. In addition, the patient experienced intermittent wrist and hand stiffness that was more prominent in the morning and never completely subsided. A previous provider attributed the stiffness and swelling to both osteoarthrosis and carpal tunnel syndrome. A radiograph from 7 months ago showed advanced basilar thumb osteoarthrosis, less advanced osteoarthrosis of the carpal joints, and mild osteopenia. She was referred for a diagnostic ultrasound and possible ultrasound-guided carpal tunnel release. Her physical examination revealed bilateral swelling and palpable synovial thickening of the second and third MCP joints, as well as palpable dorsal wrist joint pain. A step-off deformity of the first metacarpal bone relative to the trapezium was also noted. There was decreased sensation in the fingertips and the median nerve distribution, along with moderate thenar atrophy. In the organization where I currently practice, patients will more frequently undergo a diagnostic ultrasound of the wrist with a focus on the carpal tunnel as part of the workup for carpal tunnel syndrome. Electrodiagnostic studies are typically reserved for more complex cases, such as when there may be coexisting nerve pathologies or when further confirmation of median nerve compression in the carpal tunnel is helpful in establishing a diagnosis. I recognize that this represents a paradigm shift, but ultrasound offers several advantages. These include a more patient-friendly experience, greater availability, and an anatomic evaluation of the carpal tunnel, which can potentially identify anatomic variations that may increase the risk of iatrogenic injury during a carpal tunnel release. Additionally, ultrasound allows for the diagnosis of coexisting pathologies, some of which may result in median nerve compression within the carpal tunnel or mimic carpal tunnel syndrome. In the next case of the month, I will present several cases of carpal tunnel syndrome lookalikes. When evaluating the carpal tunnel with ultrasound, I always follow a protocol. This protocol takes me 5 minutes or less and enables the identification of not only median nerve abnormalities, but also coexisting pathologies or alternative diagnoses that often share symptoms with carpal tunnel syndrome. My protocol is divided into 3 parts, beginning with several views of the dorsal wrist, followed by an evaluation of the carpal tunnel, and concluding with imaging of several volar structures outside of the carpal tunnel. I review this protocol in detail in the volar wrist module of Ultimate MSK. For the dorsal wrist, I start with a long axis view of the joints and dorsal synovial recesses, as this is where intra-articular abnormalities such as a joint effusion, synovitis, or deposition disease are most commonly revealed. The ultrasound transducer is centered over the distal radius, lunate, and capitate, and I look for 2 thin hypoechoic stripes. The proximal dorsal synovial recess, located above the lunate, is an extension of the radiocarpal joint, while the distal recess above the capitate bone is an extension of the mid-carpal joint. In this patient, there is obvious thickening or hypertrophy of the dorsal synovial recesses. I also assess the recesses with Doppler imaging. The presence of synovial hypertrophy and vascularity indicates active synovitis as viewed in the lower right ultrasound image. When I detect active synovitis, I will also survey other wrist and hand structures, including the dorsal wrist compartments and metacarpal phalangeal joints. While imaging of these structures is beyond the scope of this case presentation, the ultrasound images show tenosynovitis as well as active synovitis of the second metacarpal phalangeal joint. Additionally, there is an erosion with vascularity of the second metacarpal head, reflecting active joint destruction. Moving to the volar wrist, I begin my assessment of the carpal tunnel in the short axis or anatomic transverse transducer orientation, starting in the distal forearm region proximal to the carpal tunnel. I start my imaging of the median nerve at this location because it allows me to carefully scrutinize for changes in the median nerve as it enters into the carpal tunnel. Specifically, I focus on three characteristics of the nerve: its size, shape or morphology, and echotexture. In my experience, it is the change in one or more of these features, rather than a static image, that more effectively reveals nerve pathology. The short axis ultrasound image shows the midline position of the median nerve with surrounding structures as labeled. As I slowly scan distally, the pronator quadratus muscle between the radius and ulna comes into view. I typically measure the cross-sectional area of the nerve at this location. I always take this first measurement before the nerve starts to enlarge because I want to compare the normal size of the nerve to its largest cross-sectional area more distally. By convention, the nerve should be measured on the inside edge of the epineurium as shown. In this case, it measured 7 millimeters squared, which is a typical normal value at this location. Moving distally, the median nerve traverses towards a more superficial position on the radial side of the forearm, eventually taking a position near the midline as it approaches the carpal tunnel. Going back to the distal forearm region, and again scanning distally towards the carpal tunnel, the nerve begins to enlarge, as well as the nerve fascicles. As I continue scanning distally, the nerve further enlarges and loses its typical fascicular echotexture, appearing more homogeneously hypoechoic. Hypoechoic nerve enlargement with alteration of fascicular echotexture are common sonographic findings of a compressive neuropathy. I will often scan back and forth several times as I approach the carpal tunnel to identify where the nerve reaches its largest size, which often occurs just proximal to the transverse carpal ligament complex or beneath its proximal edge. At this point, I measure the nerve's largest cross-sectional area. In this case, it measured 18 millimeters squared. While I generally consider 10 millimeters squared to be the upper limits of normal, this is not an absolute value. I discuss this in more detail in the pathology section of my wrist module. Comparing the cross-sectional area of the median nerve at the level of the pronator quadratus muscle to that of its largest size, there is a 2.6-fold increase. The upper limit of normal for this ratio is about 1.3 to 1.4, although a nerve measuring 18 millimeters square is clearly abnormal, making the ratio less relevant. Again, this is only one of the characteristics of the median nerve that I evaluate. This next image shows the proximal carpal tunnel located at the level of the tubercle of the scaphoid radially and the pisiform bone ulnarly. The transverse carpal ligament complex at this level is relatively thin and appears as a convex structure spanning between the two bones. Because I have already identified signs of active synovitis and tenosynovitis, I use Doppler imaging to look for signs of tenosynovitis of the flexor tendons, which, if present, may alter my decision to proceed with an ultrasound-guided release, since an open release would also include a tenosynovectomy. Flexor tendon tenosynovitis has two important ultrasound characteristics: the loss of the sharp borders between the tendons due to tenosynovial thickening, and the presence of vascularity. In this case, there are no signs of flexor tendon tenosynovitis. Move into the distal carpal tunnel, defined by the bony landmarks of the tubercle of the trapezium on the radial side and the hook of the hamate ulnarly. The median nerve maintains its superficial midline position. The ulnar artery is superficial to the hook of the hamate. I also assess two important branches of the median nerve: the palmar cutaneous and thenar motor branches. The palmar cutaneous branch is best imaged in a short axis transducer position, starting again at the distal forearm region. As I scan towards the carpal tunnel, the palmar cutaneous branch appears as a single hypoechoic dot that branches from the radial side of the median nerve and takes a position between the flexor carpi radialis tendon radially and the median nerve ulnarly. Its identity is further confirmed as I scan distally and observe it traversing into the palmar subcutaneous tissue. Imaging the thenar motor branch begins in the mid to distal carpal tunnel. Starting in the short axis transducer orientation, I slowly scan distally, looking for a hypoechoic dot or line branching from the nerve and traversing towards the thenar muscle group. When the thenar motor branch is difficult to visualize, as in this patient, I often scan slowly back and forth to improve nerve visualization. One technique that I use to better visualize the thenar motor branch is to rotate the ulnar end of the transducer distally to better align it with the presumed long axis of the thenar motor branch. In the illustration and corresponding ultrasound image, I first rotate the probe while scanning distally, allowing the thenar motor branch to be nicely viewed as a hypoechoic line emerging from the median nerve. I then scan back and this time maintain the probe's short axis transducer orientation as I scan distally, which results in a less conspicuous thenar motor branch. Finally, I re-image the thenar motor branch with probe rotation for better visualization. Once I assess the carpal tunnel in short axis, I next rotate the probe to a long axis position and image both the median nerve and transverse carpal ligament complex. In my experience, there are two important features of the carpal tunnel that are better assessed in the long axis position. The first is narrowing of the median nerve, whether it's a generalized narrowing or a focal caliper change. In this case, I don't see an obvious narrowing within the carpal tunnel. We see in this companion case a focal narrowing of the median nerve. Secondly, I also assess for thickening of the transverse carpal ligament complex. Most commonly, I see thickening of the transverse carpal ligament complex in the mid to distal third with a corresponding narrowing of the median nerve, as shown in this companion case. Finally, my protocol includes 3 volar images of structures outside of the carpal tunnel. The first is a short axis image of the thenar muscles looking for signs of atrophy. Normal muscle echotexture is generally hypoechoic, and in this case, the muscles are diffusely hyperechoic due to fatty replacement. I will often do a contralateral comparison view, but in this case, the patient had bilateral carpal tunnel syndrome and thenar atrophy. The thenar muscle atrophy may also be a result of advanced basilar thumb osteoarthrosis. A second image that I always obtain is a long axis view of the flexor carpi radialis tendon as it traverses over the scaphotrapezial joint. I include this image because flexor carpi radialis tendinosis can be a volar wrist pain generator and have overlapping symptoms with carpal tunnel syndrome. One of the nice features of ultrasound is the ability to correlate identified pathology with sonopalpatory pain. In this case, the patient did have pain over the flexor carpi radialis tendon. When I identify symptomatic flexor carpi radialis pathology, I discuss with the patient the expected relief of symptoms from a carpal tunnel release versus those arising from flexor carpi radialis pathology. In summary, this patient not only had carpal tunnel syndrome, but also synovitis and tenosynovitis suggestive of an inflammatory arthropathy, along with flexor carpi radialis tendinosis. I have diagnosed multiple cases of inflammatory arthropathy by using this protocol for my carpal tunnel evaluation. My systematic approach to the sonographic evaluation of the carpal tunnel is efficient and, with some practice, can be completed in about 5 minutes. This approach has allowed me to routinely identify other pathologies that may coexist with carpal tunnel syndrome, which, in turn, can influence clinical decision making. Occasionally, I also identify pathologies that mimic carpal tunnel syndrome, which I will present in the next case of the month. Ultimate MSK features a collaborative space that is open to everyone without requiring a subscription. I invite you to leave a comment, ask a question, or share an interesting image to help build the MSK ultrasound community.